Hello everyone. Today I will be presenting part 2 of comprehensive management of open abdomen, focusing on the principles, techniques, and outcomes associated with this critical condition. My name is Adiodatus Yuda Handaya, and I am honored to bring insights from my clinical and academic experience at Sarjito Hospital and Gajah Mada University, Yogyakarta, Indan. A case of a 41-year-old male with an open abdomen (OA) following an abdominal injury 3 weeks postoperatively. Image A displays a clean open abdomen without adhesion or fixation. The bowel loops are exposed, but the absence of adherence or fixation makes this patient suitable for definitive closure. Image B illustrates the successful outcome after definitive closure, with the abdominal wall restored and the midline sutured. This case highlights the importance of identifying clean OA conditions early, enabling timely and effective definitive closure to prevent complications and promote recovery. A case of a 53-year-old male with a contaminated open abdomen following the development of an ilioperistomal fistula 3 weeks postular ultra-low anterior resection with protective ileostomy. Image A shows the contaminated OA with no significant adherence or fixation but with a visible fistula and surrounding tissue inflammation. Image B demonstrates the repair of the fistula and leak, followed by the initial stages of wound closure with sutures in place. Image C displays the final outcome after definitive closure, showing successful restoration of the abdominal wall. This case highlights the importance of addressing contamination and fistula repair before proceeding to definitive closure, ensuring optimal recovery and minimizing complications. A case of a 65-year-old male with an open abdomen OA due to an enteric leak following an anastomosis 2 weeks post-gastrojejunostomy shunt. Image A shows the open abdomen with a visible enteric leak and no significant adherence or fixation. Image B demonstrates the repair of the leak and initial closure with sutures placed along the midline incision. Image C highlights the successful definitive closure of the abdominal wall, with the incision healing effectively. This case emphasizes the importance of managing enteric leaks promptly and efficiently to allow for successful abdominal wall closure and reduce the risk of further complications. Peritonitis management algorithm, which emphasizes a multidisciplinary approach for effective treatment. The process begins with surgical re-evaluation, including clinical examination to identify signs such as peritonitis, ileus ischemia, or sepsis. Identification of an inflammatory focus is achieved through imaging modalities like CT scans, ultrasound, or chest X-rays. Based on findings, interventions may include relaparotomy, on-demand or planned, or CT/ultrasound-guided drainage. Antimicrobial therapy is initiated, starting with broad-spectrum antibiotics and transitioning to targeted therapy after pathogen identification through culture or PCR-based methods. Intensive care management focuses on patient stabilization, including enteral nutrition, analgesia, sedation, thromboprophylaxis, and monitoring for new organ dysfunction such as cardiopulmonary or renal complications. The algorithm underscores the importance of daily re-evaluation and teamwork among surgical, medical, and critical care teams to manage ongoing peritonitis effectively. Overview of the antibiotic guidelines for community-acquired secondary peritonitis. As per the 2016 Surviving Sepsis campaign, mild peritonitis and localized infections are treated with broad-spectrum antibiotics such as amoxicillin/slavulanic acid, cephalosporins with metronidazole, fluoroquinolones, ciprofloxacin, levofloxacin. Combined with metronidazole, diffuse peritonitis requires more robust therapy, including piperacillin/tazobactam, carbapenems like ertapenem, tigecycline, cephalosporin combinations with metronidazole. For tertiary peritonitis or ongoing infections involving resistant organisms like Enterobacteriaceae ESBL, VRE, MRSA, or Candida species, advanced antibiotics such as tigecycline, meropenem or imipenem with linezolid, ceftazidime/avibactam with metronidazole are recommended, often combined with antifungal agents like echinocandins for fungal infections. This classification ensures targeted antimicrobial therapy to address the severity and resistance patterns of the infection effectively. Multifactorial etiology of enteroatmospheric fistula (AF) in the context of an open abdomen (OA). Several contributing factors include iatrogenic lesions caused during laparotomy or relaparotomy procedures, postoperative anastomotic rupture leading to leakage and fistula formation, dehydration, swelling, and ischemia of the intestine which compromise tissue integrity, exposure of the bowel to materials used for temporary abdominal closure, increasing the risk of damage and infection, adhesions between the bowel and the abdominal wall, along with wound infections, further complicate the condition. These factors underscore the complexity of managing OA and EAF and the need for meticulous surgical and supportive care. Classification of enteroatmospheric fistulas (EF) based on multiple criteria to assist in clinical decision-making. Anatomic location. EFs can be classified as proximal, stomach, duodenum, jejunum, or proximal ileus or distal ileus, impacting the type of surgical and nutritional management required. Output volume categorized as low, less than 200 milliliters per 24 hours, moderate 200 to 500 ml 24 hours, or high, greater than 500 milliliters per 24 hours, which influences fluid and electrolyte replacement strategies. Location inside the open abdomen. Fistulas can be superficial, draining onto granulating tissue, or deep, draining into the peritoneal cavity, posing higher risks of infection. Number of fistula openings, classified as single, multiple nearby fistulas, or multiple distant fistulas, which affects the complexity of surgical repair. This classification, adapted from D. Saverio et al., provides a structured approach to understanding the complexity of EAF and tailoring management strategies. Accordingly, updated algorithm for the management of enteroatmospheric fistula (EAF) in patients with an open abdomen. The approach is tailored based on the presence of sepsis and the characteristics of the fistula. Acute fistula with uncontrolled sepsis. For small and or low output fistulas, primary interventions include sutures, fibrin glue, or biological dressings. For large and moderate high output fistulas, if sealing is possible, options include vein therapy, tube vasectomy. For DPAFs, advanced techniques like fistula plugs or VC-based therapies are recommended. For superficial EFs, negative pressure wound therapy (NPWT) or fistula suspension can be used. Chronicized fistula with controlled sepsis, definitive interventions such as skin grafts, pedicle flaps, or biological dressings are performed. Planned fistula takedown is considered after 6 to 12 months to achieve full closure. This comprehensive algorithm emphasizes individualized management strategies based on fistula type, output, and patient condition, ensuring both infection control and optimal surgical outcomes. A 65-year-old male with an enteroatmospheric fistula (AF) and frozen abdomen, 2 weeks post-laparotomy and ileostomy closure due to an anastomotic leak. Image A shows the initial condition of the open abdomen with extensive wound contamination and tissue damage. Image B demonstrates progress after debridement and initial wound dressing application. Image C highlights further healing with granulation tissue development following continued wound care and advanced dressing techniques. Image D depicts the final stages of wound management with visible contraction and improved tissue integrity. This case underscores the importance of meticulous wound dressing and staged management in patients with EAF and frozen abdomen to promote healing and prepare for potential definitive closure. Thank you for your attention. Part 2. Throughout this presentation, I hope the topics we've covered have provided valuable insights into the management of open abdomen cases.